There you go. So please do feel free to turn off if you need to. So as you join in, you will be muted. That's just to help the meeting flow and just to help our doctor be able to speak freely. But please remember that you can post comments and questions and feedback via the chat facility. And then we do have a Q&A at the end as well. So we really encourage you to ask questions. So please do feel free to do that. But a reminder, in that chat facility, do not post any links or images. That's just to keep everyone safe. So if you do post links or images, we may remove you from the meeting. And then just a reminder that we are active on social media. So if you want to follow us on Twitter, Facebook, Instagram, or YouTube, it's all the same. It's at ARCC Ltd. And if you need to share this YouTube video with anyone that would benefit, then please feel free to just link them to that. So just because I can see that other people are still logging in, I'll just do 2 minutes of rolling the shoulders, things like that, to get the brain working, and then I will pass us over. So wherever you are seated, just bring your shoulders up towards your ears, breathe in all that tension, and then let it all go. Lovely. And squeeze, lift, breathe out. Lovely. And just roll your shoulders backwards a few times, just releasing, hopefully getting a bit of blood flow up to our brain so that we can absorb everything we're going to learn. And then just moving your head very gently left and right. And whilst you're doing that, just finding yourself really comfortably in your chair, nice and central. And then just release off any stress, shake it off. And then off we roll. So before I introduce our doctor today, you're going to see on your screen a little poll pop up. It's a little Zoom poll. So let me just bring that up for you. And all you have to do is just click strongly disagree, agree, or strongly agree. So you should be able to see that little thing up on your screen. Can everyone see it? It may be taking a bit of time because my Wi-Fi is a bit slow. Can you wave at me if you can't see it? Oh, thank you, thank you. Okay, so that means I need to reload it. If it doesn't work, it's not particularly vital, so don't worry. No, I think it's just that my Wi-Fi is too slow, so that's fine. I will just continue. So today we've got Dr. Jaya Mannan. She's a consultant at Croydon Health Services NHS Trust, and she has a focus on integrated diabetes, specifically community care. So thank you so much for joining us this afternoon. And yeah, please go ahead and just explain to us a little bit of the effects of fasting on diabetes.
Thank you, Lizzie. Good evening, everyone. I'm really privileged to be talking to the Croydon Borough people. A little bit of introduction about myself. My name is Dr. Jaya Mannan. I graduated 22 years ago back in southern India and came over for postgraduate training in UK. A lot of my diabetes and endocrinology training has been in the south of Thames area in King's College and South Guy's and Tommy's. I've been practicing in community diabetes specifically. That's my special interest. So if any of you have the condition, then you will be seeing me closer to your home because I do clinics largely in the community hubs. And this has been my special interest for the past 5 years. So thank you, Lizzie, for inviting me to do this talk during this wonderful period of Ramadan as well as Easter. I hope all of you had a wonderful break during the Easter holidays. And now we move on to my talk. So I'm going to share the screen. So I hope everyone can hear me clearly. I will try and do the presentation, in a way that everyone can understand. If you have any questions, or if you wanted to revisit a slide, then we can do so at the end, and also please use the chat. I won't be able to see the chat through the presentation, but I will endeavor to answer all your questions towards the end. So we move on to sharing the screen. I hope all of you can see the screen, and I can see Lizzie doing a thumbs up. Thank you so much. So today's topic would be how we can safely manage diabetes mellitus in fasting conditions. So the talk would be based on a little bit of an introduction to fasting, then what fasting does in terms of benefits, and what are the different types of fasting, then in what way it affects the body metabolism in diabetes mellitus, and what are the things that we need to consider to be safe during the fasting period. I have also collated some case studies so we can open up to the viewers at the end when we go to case studies, and we can discuss the scenario. So fasting is defined as voluntary abstinence of food and fluids for a set period of time. Simply, it means that somebody decides to stop eating both a solid or liquid diet almost completely for a certain stretch of time. This can be anywhere from 12 to 24 hours, but some types continue for alternate days or so. There are some types of fasting where people are allowed a liquid like tea, coffee, or water. It varies on the personal, social, cultural contexts. So we know different types of fasts. If you look at the social and cultural aspects of fasting, there could be fasting with relation to food, as well as with relation to several aspects of livelihood, which allows one to have a self-discipline. For example, there could be speech fast, there could be abstinence from sexual activities, but this talk is mainly going to concentrate fasting in the context of food substances. As I alluded earlier, why do we decide to fast? It could be for health reasons. Somebody decides to fast because it is beneficial for, say, for example, weight loss. By restricting calories, they may be able to do that. And also in the recent studies, the chronic illnesses like diabetes can be put into remission by doing certain calorie restricted fasting. So therefore, health reasons. So we call this intermittent fasting. This is not a continuous fasting, but intermittent fasting. This consists of alternating periods of voluntary fasting and then unrestricted calorie consumption. It is used, as I said, in various cultural, personal contexts and majorly in the religious contexts. There are three different types of intermittent fasting we may call. One is called as time-restricted eating. For example, let's say 16 hours and 8 hours. Somebody chooses to fast for 16 hours and eating within an 8-hour period, no particular dietary restriction during that feeding window. So this results in an unintentional total calorie reduction. For example, let's look at it a way of skipping one meal. So if somebody decides to finish dinner by 8 p.m., they are already achieving 12 hours of fast by 8 a.m. If they make it to noon for lunch, then they have fasted for 16 hours. So what is the alternate day fasting? Alternate day for fasting is quite popular. For example, people choose to do 2 days in a week fasting, 5:2 protocol it is called. They will be on calorie restriction for 2 days in the week. For example, they may choose to do about 500 to 800 restricted calorie diet. And then the rest of the 3 days, no particular dietary restriction will be there. It's sometimes called as complete alternate day fasting because the time when somebody don't eat lasts for full 24 hours. That can be a bit difficult to persevere in the long run. The third one is modified alternate day fasting. It is similar to the alternate day fasting 5:2. However, they reduce their calorie intake very much. They take only up to 40% of energy requirements on 2 days of the week. So the modified alternate day fasting, when it is carried out with physical activities, say, for example, jogging, walking, or aerobic exercises, then it shows the intended benefit of weight loss. So as said before, religious fasting, the context of religious fasting is popular and very predominant in the sense of fasting. So the several religions across the world follow different types of fasting pattern. We are in the period of Ramadan now, which is 29 or 30 consecutive days of fasting during the daylight hours, where no food or liquids are consumed. If we look into Hinduism, there is about 1 to 9 day period of fasting every year, which is based on a lunar calendar, and the fasting lasts from sunrise to sunset. Again, we can look in the religion of Jain, where they kind of fast on the day 8 and 14 of lunar cycle. They mainly abstain themselves from 4 major categories of food substances. In Christianity, we'll be having a Lent period fasting for 40 days. And there are other three principal types of fasting, including the Lent being nativity and assumption. And it can vary from 15 to 48 days waking hours. And this fasting might mean not consuming certain food substances during the period of fast. Say, for example, abstinence from meat, eggs, dairy products, olive oil, alcohol, etc. In Buddhism, they call it eightfold fast. They don't eat anything after noon and breakfast in the next morning, and they completely abstain from meat and fish consumption. Similarly, in the religion of Judaism, they have a 1 day, 24 hours to 26 hours of complete fasting. So this is a religious context of fasting. We will also have medical and surgical reasons why somebody would be asked to fast. And this is a common situation many of us have gone through. For example, you're going for a fasted blood glucose or blood tests, which means that you don't consume anything for about 10 hours the previous preceding evening. If somebody is going for some operative procedures, or they're going for camera tests, then they may be asked to fast for a certain period of time. Usually this is missing about 1 or 2 meals, and it is not as relevant in the sense of prolonged fasting that we see in the religious context. The hospitals follow guidelines, and people who are asked to do this fasting will be given advice on how to manage if they are on any medication, not just the diabetes medication, but all the other conditions as well. So we'll move on to seeing what are the benefits of fasting. We have seen the reasons why somebody would be fasting, and now we move on to benefits of fasting. The intermittent fasting, which I explained in the last few slides, has been shown to facilitate weight loss majorly. And in people with risks of diabetes mellitus or already have diabetes mellitus, they improve the sensitivity of insulin in the body. This leads to better glucose control. The reduction in the bad cholesterol levels and increase in the good cholesterol levels are also seen in fasting for longer duration of time. In some of the studies, scientific studies, there is positive impact on blood pressure. The exact mechanism how the fasting induces these changes, we know only a theoretical basis from animal studies. It largely comes from breakdown of fatty acids in the body, reducing the inflammation in the body, and then it optimizes the internal body clock and the physiological process which happens with the body clock. So this is found to be of greater benefit for people with chronic illnesses, say, for example, metabolic syndrome. Metabolic syndrome is where someone has diabetes mellitus, high blood pressure, increased body weight, and increased cholesterol. So it is also said fasting in the context of religious settings may lead to increased mental well-being, improving compassion, because there is a lot of social interactions during the period of breaking the fast. So the slide here shows that reduction in the waist circumference and also fatty liver disease, which is a common scenario in someone with type 2 diabetes as well. There are studies around this. So before we move on to how fasting affects the body's metabolic response, we needed to understand what diabetes mellitus is. And all of us predominantly know there are two different types of diabetes mellitus in a broader sense. So type 1, where insulin is the main mode of treatment, and it is an absolute essential and should never be stopped. The type 2 diabetes mellitus, which is seen in about 90% of people diagnosed with diabetes mellitus, can be treated with diet and or tablets and or injectables, and this can include insulin. I'm going to stop sharing here and open up a YouTube video where I want you to see this video regarding diabetes mellitus. Bear with me.
Type 1 and Type 2. They're different conditions, but they're both serious. There are some other rarer types of diabetes too. What all types of diabetes have in common is that they cause people to have too much glucose in their blood. But we all need some glucose. It's what gives us our energy. We get glucose when our bodies break down the carbohydrates that we eat or drink, and that glucose is released into our blood. We also need a hormone called insulin. It's made by our pancreas, and it's insulin that allows the glucose in our blood to enter our cells and fuel our bodies. If you don't have diabetes, your pancreas senses when glucose has entered your bloodstream and releases the right amount of insulin so the glucose can get into your cells. But if you have diabetes, this system doesn't work. When you've got type 1 diabetes, you can't make any insulin at all. If you've got type 2 diabetes, it's a bit different. The insulin you make either can't work effectively or you can't produce enough of it. In both types of diabetes, because glucose can't get into your cells, it begins to build up in your blood. And too much glucose in your blood causes a lot of different problems. To begin with, it leads to diabetes symptoms like having to wee a lot, being incredibly thirsty and feeling very tired. You may also lose weight, get infections like thrush, or suffer from slow-healing wounds. Over a long period of time, high glucose levels in your blood can seriously damage your heart, your eyes, your feet, and your kidneys. These are known as the complications of diabetes. But with the right treatment and care, people can live a healthy life. And there's much less risk that someone will experience these complications. If you've got diabetes, you can find lots of information and support about living with it using our website and helpline. As well as campaigning for everyone with diabetes to get the right care, Diabetes UK fund research into all types of diabetes so we can develop new treatments and one day find a cure. You can find
So the video has given us an idea of what type 1 and type 2 diabetes mellitus is, and you might have already seen that you can make use of the website for any further information you need. Guide to Diabetes. It is diabetes.co.uk website. So let's move on to the physiological effects, i.e. what happens in the body during the time of fasting. So fasting, there is change in the meal times leading to change in sleep patterns. Therefore, the body clock called a circadian rhythm and the hormonal processes begin to change. And the effect of this change is most visible in the initial few days of fasting, especially in the context of Ramadan, where in non-equatorial countries like in UK, the fasting hours is prolonged. And then it kind of settles, the body gets used to it. And then by about 7th day, it acclimatizes and accommodates the needs of this fasting. So let's see what happens in someone who do not have diabetes mellitus. So when a healthy individual eats food that contains starch or carbohydrates, simply put as glucose, it stimulates the pancreas, which is the yellow organ in there, to produce insulin. And this insulin promotes movement of glucose into cells for energy. And then excess of glucose is then stored into the liver and the muscle, the peripheral tissues. During fasting, what happens in people with no diabetes mellitus is the glucose levels in the blood falls because there is no external food intake. Therefore, the pancreas responds to this and stops or decreases the insulin secretion. When insulin secretion reduces, there are counter hormones in the body that goes up. The action of the counter hormones is to to keep a steady or stable state of glucose. Now, I want you to understand that glucose is an essential resource of food or energy, especially for brain and many of the vital organs, such as the heart as well, the muscles. So when glucagon goes up in the presence of reduction in insulin, it mobilizes the stored glucose from the liver as well as in the muscle. And this way it maintains a stable, steady state of glucose in the blood. So what happens in diabetes mellitus is there are two different actions happens. One in type 1 diabetes mellitus, where there is absent insulin secretion. The corresponding glucagon action is also actually reduced or minimized. It will still produce, they will still produce some glucagon, and they will still break down some glycogen reserves, the reserve from the liver and in the muscles, but they can't do so as in healthy individuals. The similar condition happens in type 2 diabetes mellitus as well. The reason why the glucagon secretion does not increase in type 2 diabetes mellitus, if you remind yourself of the lock and key scene from the little video that was played, you will see they will have excess of insulin in the body, but this insulin will be ineffective in moving the glucose into the cells. So when there is increased insulin in the blood, the glucagon thinks there is enough insulin, so therefore there will not be any secretion of glucagon. Again, that leads to detrimental effect of moving the glycogen stores, or moving the storage into the glucose to maintain the balance. There will also be increased breakdown of fatty substances, and it produces a metabolic product called as ketones. The ketones, in the extreme situation of insulin deficiency, and when there is no glucose usage in the cells, the ketones will be used as an energy substrate. And this forms the basis and principle of some of the extreme diets where people don't eat any carbohydrate at all. And I suppose that is a discussion on its own at a different time. And today we will just concentrate on this. So the abnormal action here is excessive breakdown happens, and therefore there will be increased glucose levels in the body more than the target or the stable levels, and increased fatty acid breakdown in the body, producing the substances called as ketones. So when someone with diabetes mellitus chooses to do prolonged fasting, there are risks associated with that. The first of the risks will be dehydration, severe dehydration. As the blood glucose levels goes high in the blood, the cells require a lot of water. And when the fasting involves no water intake or liquid intake, then it kind of aggravates the dehydration situation. When the body is dehydrated or loses the water, the tendency to blood clot increases. We call that as thrombosis. And during those periods, people who are prone to develop clots in the legs or in the lungs will be at high risk. The other risk associated with prolonged fasting, when people don't adjust the medications or take the medications as usual, will be low blood sugar, because the substrate, we don't give any food for the body. Low blood sugar is one of the risks associated. So what would be the symptoms of hypoglycemia or low blood sugar? I.e., when the blood glucose, when it is measured, when it goes less than 4 or under 3.9 millimoles per liter, it's a condition called hypoglycemia. As it goes further low, say under 3 millimoles per liter, people will start feeling many of the symptoms, starting with trembling, sweating and chills, palpitations, hunger, the need to eat sugary food. There will be a degree of confusion and headache. On the other hand, when the blood glucose levels go above, for example, over 16.6 millimoles per liter, there is specific reason why this threshold is there. There will be extreme thirst. And again, this will manifest itself as hunger, frequent urination, lethargy or increased tiredness, confusion, the feeling of sick feeling, and tummy pain. It's important to recognize these symptoms. At the same time, it is important to know what the blood sugar value is, because if you see there is overlapping of hypo and hyperglycemic symptoms, for example, you can see hunger and confusion happens in both. Fasting during the period of Ramadan has been one of the extensively studied fasting situation in the world Muslim countries. So one such study is called as Epidemiology of Diabetes and Ramadan study. It was a study that was carried out in 13 largely Muslim populated countries. And the study showed that severe hypoglycemia increased about 5-fold during the period of fasting, as well as the high blood glucose values over 16.6 millimoles also increased during the period of fasting. So if you see on my left-hand side, I've said severe hypo about 5-fold. On the right side, you will see non-fasting. If they had 5 high glucose events in 100, during the fasting period, it more than tripled to 17. So severe hypoglycemia is different from mild or moderate hypoglycemia. Severe hypoglycemia is a situation where the person who experiences low blood glucose cannot treat themselves, and they will need a third party or third person help to recover from hypoglycemia. This could mean somebody being helped by their family members to requiring ambulance call because they faint, or hospital admission to rescue them from low glucose by giving drips. The other important risk associated when the blood glucose goes very high is a condition called as diabetic ketoacidosis. When a healthy individual or non-diabetic individual, for example, follows a strict carbohydrate limiting diet, they will automatically put their body into a condition called ketosis. As explained before, ketosis is a condition where when there is no glucose, the body breaks down the fatty acid and uses ketones as an energy substance. The ketoacidosis is actually a life-threatening condition where the ketone bodies increase in the blood and the cell acidity or the acid-base balance changes over a period of time. And as you can see in this little cartoon, it can set up in a period of over 4 to 10 hours. And there will be several kind of symptoms such as increased heart rate, low blood pressure because of acidic changes in the cells. There will be a fruity smell to the breath. and the respiration or the breathing becomes abnormal. There'll be a lot of respiratory effort to kind of breathe out the excessive acid. The high blood sugar will be in type 1 diabetes. It can be 11.1 millimoles per liter or over. And in type 2 diabetes mellitus, diabetic ketoacidosis usually doesn't happen, but it is, you can also see this in type 2 diabetes in the later stages of the illness or in some ethnic origins. So this is a dangerous condition which needs hospital admission, and then they'll have to be given drip fluids and then insulin via the bloodstream. So all the studies that have concentrated on fasting and the physiological effects showed us that we needed to identify individuals who may fall into certain risk categories when they choose to fast. What are the factors that indicate the level of risk involved in fasting would be the type of diabetes. Type 1 diabetes mellitus is known to have a higher risk in the fasting situations. Medications, especially when they are on medicines that will reduce the blood glucose. The most common one that you may all know is insulin. The other common one you may have heard is glucoside and the family of drugs called sulfonylureas. The third factor that determines if an individual will develop low blood glucose in increased episodes will be their own threshold. Comorbid conditions. What are comorbid conditions? If someone has kidney failure or heart failure or liver failure, or they experienced heart attacks or strokes in the past 6 months, or they experienced hospital admissions related to high or low glucose in the preceding 3 months to a period of prolonged fasting. Individual social and work circumstances. What do they mean by work circumstances? Is someone who takes up intensive physical labor during their working hours are prone for low blood glucose levels and prone for dehydration. And lastly would be the previous fasting experience, how well they have managed prolonged fasting in the past, how did personal experience here comes handy, how did they adjust their medications, or how did they manage the extreme risks during the period of fasting also indicates the level of risk someone might fall into. So based on these parameters, we kind of divide an individual with diabetes into 3 categories of risks. One is low risk, moderate or intermediate risk, and a high or very high risk categories. So low risk, these are people with diabetes who can fast with advice. Usually before a period of prolonged fasting, the advice and the guideline is that they contact their healthcare professional, i.e. the GP or specialist doctor, about 3 months before with the intention of getting the right support and education prior to embarking on prolonged fasting. So who would be at low risk? Someone with type 2 diabetes on diet control only, or people with type 2 diabetes with oral tablets, and that type 2 diabetes is well controlled, i.e. their daily glucose levels will be as close to normal as possible without any low glucose episodes. They will be able to fast with minimal education and self-management. And also a recent medical history that they are otherwise healthy. The second category is intermediate risk. These are people who can fast with advice, but they may need supervision through the fasting, but not as intensely as the high risk, which I would be talking to about in a few minutes' time. So who are the intermediate risk category? These are people who have stable type 2 diabetes mellitus, and they may even be on medications such as sulfonylureas, which will reduce the glucose levels. Their longer-term glucose control, which is measured by the lab parameter called HbA1c, is somewhere between 7.5 to 8.5%. This is the old value, without much complications to their heart or eyes or other organs such as kidneys. Again, the advice would be that they contact their healthcare provider earlier on to have the right support and management plan individualized to them. The third category, high risk, the recommendation and the suggestion is talk to their doctors. The international guidelines is the advice is not to fast. However, people may choose to, people may want to fast, and they will need quite close monitoring and support, including a clinic review during the period of fasting as well. So who are the people who might fall into the high risk category? Would be type 1 diabetes mellitus, type 2 diabetes mellitus with a history of hospital admission related to glucose variability in the past 3 months, people who undertake intense physical activities through their working hours or part of their job. The glucose control may not be as well controlled as we would want it. For example, the HbA1c over 8.5%. One of the complications in type 1 diabetes mellitus is over a period of time, and when someone constantly experiences low glucose values, the body resets its threshold. It thinks that hypoglycemia is a normal event and it doesn't give enough warning to them to act on time. So this is called as hypoglycemia unawareness or reduced awareness. This is a complication and a potentially dangerous situation. It is quite unpredictable and a volatile situation where the people can kind of faint, get fits because of low blood glucose, and they are totally unaware of the symptoms until they go down to 1 millimole per liter, sometimes even less than 1 when they are admitted to hospitals. Again, people who have kidney problems, heart failures, and acute illness, say, for example, in the context of the pandemic COVID-19, if they have symptoms of COVID-19 and they are acutely unwell with fever, they may be high risk of carrying on fasting. Pregnant women and breastfeeding mothers with the diabetes mellitus, because they lose a lot of energy and calories and they are prone for hypoglycemia. In pregnant mothers, high fluctuation in blood glucose levels when they undertake fasting may have adverse effect or bad effects on the growing fetus. So how do we kind of tackle these risks? So 3 major actions are required to risk minimize and safely carry out fasting, whatever category the person may fall, say intermediate or high risk category. We can do risk minimization by 3 major actions. One is regular blood glucose monitoring. I will talk in detail about that. Next is advice around the lifestyle activities, including medical nutrition plan and exercises. And thirdly, and most importantly, how to adjust the doses of the medicines they may be on. It is very, very important and vital to understand when to break the fast. So the 4 major things is when somebody experiences features of low glucose, high glucose, or dehydration. When they have an acute illness during the period of fasting. And for the ease of understanding, there is definition of what is low blood glucose and what is high blood glucose in the 3rd row there. And especially for people who may be on insulin or sulfonylureas when the blood glucose is low. These are the time when the fasting has to be absolutely broken and they have to feed the body with food and water. So blood glucose monitoring, let's see in the context of, let me quote an example. Let's say we are going to a new place where we have not been there before, and we don't have any means of identifying how to go there, a situation where we might make use of the SAT navigation, which is which we have in the smartphones, even in this era of technology. So think of blood glucose monitoring in the sense of a satellite navigation, that what is happening to your blood glucose levels at different points of the day, after meals or before meals, in the context of physical activities, resting, as well as in fasting. Therefore, blood glucose monitoring is a kind of an eye opener, like a sat nav, as to what is happening to the body's physiological mechanism. So having a stable or at least or near normal optimal glucose control before fasting becomes an important factor to ensure safe fasting. So the slide here shows some examples of different timings of blood glucose monitoring, and I have quoted the example of Ramadan fasting. As I said, there are several studies around this. So before sunrise, around midday, and before the evening meal or sunset, and whenever they feel symptoms of high or low glucose. For people who fall into the high risk category, the second row down, they may be able to do like 6-point blood glucose monitoring throughout the period of fasting, as well as at the breaking of fast period. So why do we say before the evening meal is to, that's the time when they are more prone for low glucose values. And 2 hours after the breaking the fast, it is important to understand if they have to adjust or give extra insulin in the context of type 1 diabetes mellitus. So likewise, why do we need to do blood glucose monitoring in the morning hours is to understand there will be more than 10 hours or 8 hours of fasting that's going to come. And what are we going to do about the insulin doses if somebody is on insulin? Are they going to give the same dose before fasting, or are they going to reduce it? So to have an idea of what the dose should be, you need to know what your glucose should be. So therefore, these are the different points in the time during the period of fasting that someone can consider doing blood tests. With growing technological advances in diabetes mellitus, especially glucose monitoring, people may choose to ask their healthcare professionals, their specialist diabetologists or GP about the new kind of monitoring technologies, which is called as sensor monitoring, continuous glucose monitoring, flash glucose monitoring, to aid them to be safe during the period of prolonged fasting. Having said that, we have to bear in mind there are criteria that NHS England follows around provision of these gadgets. And the good news to people listening is there is a nationally recognized need to provide this for more people, therefore changes are coming up. So watch the space. So I want to move on to lifestyle advice. So twofold lifestyle advice, one around the nutrition, the other around the exercise. So for someone who chooses to fast and break the fast, there is the medical nutrition plan. The medical nutrition plan can be, you can choose to read on websites. Diabetes UK has got a lot of advice around fasting and diabetes mellitus and managing. Or you can choose to ask your specialist dietitian around what would be the best way to manage so that the glucose doesn't fluctuate to the extremes. So the general rule of thumb here would be 45 to 50% of your per meal would be made up of complex carbohydrates. Example, it could be the whole grain, rice or wheat, food made out of that, beans and lentils. Then about 20 to 30% of that proportion should be proteins. For example, lean proteins, nuts, and then less than 35% should be made up of fat. So avoiding high saturated fat or deep fried foods such as samosas, pakoras. There are some examples, use of ghee, etc. Try and using vegetable oils, avoiding sugary desserts for at the end of the big meal. Avoiding caffeinated and sweetened drinks will help you prevent dehydration. So that plate there is designed to provide about 500 kilocalories per meal, with majority of energy source coming from carbohydrate. Protein is there to kind of give you that filling feeling, and also it kind of prolongs the release of the glucose in the body. So for people who are prone for low glucose levels, having in the Ramadan context, a pre-suhoor meal with a low GI index and high in protein will help them tackle the low glucose events during the period of prolonged fasting. And then as much as possible, drink a plain to non-sweetened drinks during the permissible hours of feeding. Exercises and fasting also is a education around that is required. Regular light to moderate exercise, say for example, you're going for a usual walk in the park, you're taking your dog to a walk, light to moderate exercise is generally considered safe. Rigorous exercises usually recommended once people break the fast in the evenings, if the fast is from sunrise to sunset. And especially if they're on insulin or oral agents that will drop their blood glucose, it is considered better to do the exercise after they break the fast. And for people who follow the Islam faith, it is to be considered their certain prayers, nightly special prayers involve repeated cycle of rising, kneeling, and bowing is considered as a part of the exercise as well. So when they kind of adjust the doses of insulin, they have to bear in mind about this. So we come to the most important part of the talk now. It's about the medicines management. So I've tried to be as comprehensive as possible. This is a general kind of an advice, and it is by no means individualized. If you need individual medicine management plan, then you'll have to talk to your GP or your specialist doctor. So this is for your overview only. So in diet control diabetes, the medical nutrition plan and the physical activity, that is the exercise regime, becomes important. They don't have any other medicine adjustment advice required there. So metformin, most of the people with type 2 diabetes will be on metformin. There is no dose adjustment or timing adjustment largely not required in metformin because it is considered to be a medication that is neutral and it doesn't usually push people into low glucose events like insulin or glycoside and sulfonylureas. So next on the row, you will see the sulfonylureas I was talking about, and the class of medication in these will be glycoside, glimepiride, glibenclamide. In the Croydon area, we largely use the glycoside and some glimepiride. And the events of low blood sugar episodes are increased when somebody takes the glycoside. And you will see a graph on to the right side in the top where there was a study in people who were fasting and using the different types of sulfonylureas. Out of that, glycoside was comparatively caused less low glucose events to the other two types of sulfonylureas. Therefore, if someone, say for example, if someone remains on glibenclamide, they may need to talk to your GP before undertaking the fasting, and the GP can consider changing to glycoside or one of the other medications that should be suitable and not cause low glucose episodes. The other commonly used oral tablets in diabetes are the ones called as the family of DPP4 inhibitors, and you will see the examples quoted there: sitagliptin, which is largely used, linagliptin in the Croydon area. The low blood glucose episodes when compared to sulfonylureas, when people used sitagliptin, was almost half. There was still some low glucose episodes, but it was not as high as the sulfonylureas. And the second graph onto my right, will show you the study that showed this difference. So when somebody is taking these medications, these tablets, it will be usually once a day preparation, and no dose adjustment or timing changes are required for this tablet. So the third type of, the other type of tablet that people might be on is called as thiazolidinedione, so a mouthful of pronunciation. So example is a pioglitazone tablet. No change in timing or dose would be required. The next one is a new kind of a medication which has come to the market, which has got beneficial effects over the kidneys and heart as well, and is being commonly used as second line agents even after metformin for type 2 diabetes mellitus. They're called sodium glucose cotransporter 2 inhibitors. An example in this class are medication that ends with gliflozin, they end as gliflozin, DAPA, CANA, empagliflozin. No change in dose is required. However, this will cause people to dehydrate, and some cases there will be ketoacidosis in these medications. Therefore, adequate education for people who are going to take this medication and following what is called a sick day rules when they are on these medications is really needed. So if they become unwell with a fever or a condition where they may lose fluid from the body, such as diarrhea and vomiting, they have to stop this medication. Usually the international guideline is do not start anyone on a new medication when they are embarking on a fasting period. Rather, start them earlier on, up to 3 to 6 months before, to see how they are tolerating. Is there any side effects? Give them time to get adjusted to these medications. Down on the table would be the injectable. People with type 2 diabetes mellitus might be offered. The common examples of Victoza or liraglutide or Trulicity or dulaglutide. These are once daily to once weekly preparations. These are found to be really effective in reducing the post-meal, high glucose levels. So therefore, no changes to doses or timing is majorly required in fasting. However, some people will experience tummy upset. So those people may need a dose reduction prior to embarking on prolonged fasting period, or dose reduction by about 50% or going to the lowest dose possible. So lastly, coming on to insulin. It is very important to understand how different insulin acts. So you might have heard different types of insulin, from longer acting, which has duration of action up to 12 to 24 hours. There is an ultra long acting in the market, which can act up to 36 hours in the body. To rapid acting, they peak and then get out of the system within 3 to 4 hours. Short acting, where they peak within again half an hour to an hour, and then they are in the system for up to 6 hours, and then they are excreted. Intermediate acting insulin, where they may be in the body for up to 10 hours. So what is required in the studies? We have found that long acting or background insulin, where majority of type 1 diabetes people and some with type 2 diabetes mellitus will be on. The total dose of this background, we call it background insulin or basal insulin, the total dose may need to be reduced by up to 25%. In some scenarios, for example, in young people, it has to be reduced up to 30%, 15 to 30%. Intermediate acting insulin, the same kind of dose reduction between 15 to 20%. So the mealtime insulin, name itself indicates that if you don't have a meal, then you don't take this insulin. The advice to type 1 diabetes mellitus will be slightly different because they are completely deficient in insulin. Therefore, they will use what is called as correction dosing of this mealtime insulin. The mixed insulin, many people with type 2 diabetes mellitus will be on 2 times a day, what is called as mixed insulin. Example, Novomix 30, Humulin M3, Humalog Mix 50, Humalog Mix 25. They are a mixture of short-acting as well as intermediate-acting insulin. So what should happen is this needs dose adjustment, usually reversing the dose. I've quoted some example that if someone is on before fasting, they take 32 units in the morning and about 24 units in the evening. During the period of fasting, they will need half the dose in the morning and they will take the morning dose in the evening because their major meal will be in the evening. So as I said, this is a general guidance and overview for individual management plan. Each of you needs to talk to your own GP or specialist doctors. So lastly, we'll come to, can adolescents and young people fast? Yes, they can. So about 80% of physicians who take care of adolescents and young adults with diabetes mellitus allow them to fast if they wish, provided they are given focused education around how to monitor glucose, how to count carbohydrate, how to adjust insulin or medication. And they agree to come for close follow-ups, management plan review, balanced nutrition, and again, insulin medicine adjustment. They can fast safely. So in all, shared decision making is the most important thing. It is shared decision making between the person with diabetes and the healthcare professional, and the family and caregivers are also play an important role here. So the goal of care would be prevent complication and optimize the quality of life, and allow them here in the context of fasting and diabetes, allow them to have a safe and successful fasting. So the assessment would be individual characteristic, their lifestyle, do they have any complications, how old are they kind of frail, elderly, what is their control like, the willingness to self-manage and motivation to engage, are they of sound mental health, is there any cultural, socio-economical pressures or context. And then you kind of work on the individualized targets. Do we need to simplify the regime, or we needed to give a more flexible regime? What side effects are to be considered here, and what are the cost and efficacy and access to certain medication? Then actively seek what the person wants. Have a motivating consultation and education around the condition, both for the person with diabetes as well as the caregivers. And the goal would be empowering them with information and education around safe and confident self-management. Agree and implement the plan. Then review with ongoing monitoring and support. So this should be the goals of care, and it is shared decision making. Right, I'm almost to the end of the talk, and I'm going to present some case studies. Basically, we will identify the risk category, and we will identify what needs to be done to allow them to have safe fasting. Any questions until now?
I think that Naseem had some really good questions. So if you unmute yourself, please feel free to go ahead and ask Naseem.
Hi.
Hi.
I was just wondering, because I'm not on medication, I'm on type 2 diabetes, but I am fasting in Ramadan. And I was just wondering, is it necessary to check your blood sugar levels regularly while fasting, even though you're not on medication?
Naseem, that's a very good question, and I'm sure many of the other viewers might have the same question in their mind. If you are on diet control diabetes only, usually there is no need to check your blood glucose, but it becomes important to kind of follow the medical nutrition plan that I described, the balanced diet, and keep to, the physical activity to the level that will support your fasting. So you won't need to do regular blood glucose monitoring, no.
Okay, thank you. Another thing, just prior to opening your fast, a good sort of 3 hours prior to opening your fast, I feel quite weak, tired, lethargic. Why is that?
So it really depends on the context. As I said, both low glucose and high glucose has overlapping symptoms. Yeah. So it could simply be that it should be put in the context of what the last HbA1c was, how you have been feeling well in yourself prior to embarking on the fasting. So it could be simply that the body is deprived of a major energy source, and it could be a natural physiological response to feel so. If you have any doubts in whether, if you think you might be going very low in the glucose levels, or your glucose levels sometimes might be very high, in the context of that, you may need to do some finger prick tests.
Okay, thank you so much.
You're welcome. Any other questions? Shall I move on?
Yeah, go ahead with your case studies, because that might bring up some questions anyway.
Yeah, okay. So moving on. So let's look at Mrs. I. She is aged 38 years and a BMI of 27.5, which is categorized as on the overweight side. And she has 3 years of type 2 diabetes, and she's being treated with metformin, glimepiride, which is one of the sulfonylurea classes. And her HbA1c was 8.1% at that time. Since adding the glimepiride, the weight has gone up, which is a known factor with glimepiride, and there could be other reason. And she attends a clinic review 3 months before the proposed religious fast. And the HbA1c has gone down to 61 millimoles per mole. And she had low glucose episodes because she was very busy at work, at least 2 times before that review. She doesn't do many self-monitoring of blood glucose measurement, and she heard from a friend that it should not be done. So there are several kind of questions that might arise in your mind as to what should be done if she has to be safe during the fasting period. Yeah. And what would be the risk category, bearing in mind the previous slides of low risk, intermediate, moderate risk, and high risk. I shall open it out to the viewers, and I'm happy to hear some answers and explanations. Any volunteers? I'm unable to see any of you, so please go ahead. Any volunteers?
You can unmute, but also there is a little button on your screens where you can put like a virtual hand up as well. So please feel free to do that, although people might be shy.
Any volunteers, Lizzie?
I don't think so.
All right. So I'm going to go ahead with this. So basically, if you see the duration of type 2 diabetes duration is well within 5 years, but Mrs. I remains on a potentially low blood glucose causing agent, that is the glimepiride, and she also has low glucose episodes in the preceding months to fasting. The sentence on weight has increased by 1.5 kilograms shows that she may have experienced low glucose episodes requiring treatment with sugary substances, which is one of the reasons somebody may put on weight when they are on agents such as sulfonylureas or insulin, one of the reasons. So she falls basically into an intermediate risk category based on the HbA1c, the experience of hypoglycemia, and the medication risk. So it says she usually doesn't do many self-monitoring, and she heard from a friend that it should not be done. So, well, that is a wrong advice she has received from a friend. If someone is on sulfonylureas or agents that will lower your blood glucose, you can by all means talk to your doctor about getting a glucose meter to monitor, and it is essential for you. There might be, in the religious context, many of the studies have spoken to scholars around the world in the Islam faith, and it is said in the Islam faith that measuring a blood glucose or finger pricking is not considered as breaking a fast, so it can be carried out. And if you remember the timings of blood glucose monitoring, Mrs. I takes glimepiride once a day, 2 milligrams per day. So I'm assuming she might be taking it in the morning hours. So two things should happen. She should be able to check her blood glucose before 2 hours or prior to breaking the fast in the evening, because that is the period when she might feel more low, like one of our viewers described before, although they are not on any medications. So she needs to measure before breaking the fast in the evening, and then she has to do a blood sugar before the morning meal as well. So overall, it may be that she needs reduction in the dose of the glimepiride. If she sees the doctor would do that. And then follow the medical nutrition plan and the exercise advice associated with it. The other option would be that the doctor might want to choose to change the medication entirely to a different one. Instead of glimepiride, they may choose to give a different medication. However, the advice is don't do much changes during the period of fasting unless otherwise it is much needed. So case study 2, Mr. Y, a businessman who is on the obese category based on the body mass index. He has 5 years of type 2 diabetes. His HbA1c is 66 millimoles per mole, which from an eye of a diabetologist, I would say it can be more satisfactorily controlled. It can be brought down a little bit more. And he is on, again, Metformin, the first agent, and the second agent being sitagliptin. So if you would remind yourself from the slide, sitagliptin and Metformin usually do not cause that many low glucose episodes. It is not 100% that they won't cause. There will be some episodes of hypoglycemia or low glucose with sitagliptin, and that has to be borne in mind. So this person, it is described as he has tendency to eat frequently in business meeting or at hotels, and he travels quite frequently. He also consumes a lot of sweet substances, and he has always carried out fasting. In addition to type 2 diabetes, there is high blood pressure, and he is on medication for that. With the blood pressure number, that means that it has to be optimal. It has to be lower than what is seen as 145/85. And his low density cholesterol, which is termed in quotation as bad cholesterol, is on the higher levels than recommended. And he also takes cholesterol lowering agent for that. So how should he approach fasting? Again, based on the duration, age, and HbA1c and the medication, the risk category is intermediate or moderate risk category. Prior to the fasting, this person definitely needs a healthcare professional review with advice to take on type 2 diabetes focused structured education. If you are familiar with the term called DESVEN, that is type 2 diabetes focused structured education. It is available on Book and Learn Diabetes booking.co.uk. If you haven't done that, I would encourage you to do it. So education. The next is it predominantly looks like he will need his blood glucose can be optimized with nutritional advice or dietetic advice. Therefore, if he kind of chooses to follow the medical nutrition plan, he may use the fasting period safely to twofold benefits. One, he religiously fasts. Secondly, it will be beneficial for his health in terms of weight loss, because fasting has shown about a weight loss of up to 1.5 kilograms, not more than that in the period in the period 30 days after Ramadan fasting, people have lost weight as well. So he could safely fast with the proper management plan and advice around nutrition, activities, and not so much of dose adjustment. If he goes to the doctor 3 months prior, then if I was his doctor, then I would look to add or give him an injectable that would be weight neutral or even facilitate weight loss, so that won't have an adverse effect on his fasting. So the next one is a 61-year-old woman with body mass index of 29, which is on the overweight side, close to obesity. So 12 years of type 2 diabetes, now requiring insulin once a day. Insulin degludec is a longer acting insulin, which has got 36 hours, up to 36 hours of duration of action. She takes it in the morning, and then metformin 1 gram in the morning and evening. Again, they have eye changes, high blood pressure, and she presented with very high glucose and dehydration, requiring hospital treatment 12 years ago, actually. So this is not within the past 6 months, 3 months. The HbA1c, I would call it, is not satisfactorily controlled, and they experienced a low glucose episode, severe low glucose episodes 2 months ago. So what should be the approach for safe fasting here? So moving on to the answer for this is, this lady is categorized to be in the high risk. One, because of the severe hypoglycemic episode in the preceding month, the HbA1c on the higher side, her low glucose threshold and awareness might be of question here. So therefore, again, the high risk category, they should take up the focused education, close monitoring during the period of fasting if they choose to, dose adjustment to the insulin degludec. They might need dose reduction or even keeping the same dose depending on how their blood glucose pans out. Blood glucose monitoring, like the 6-point tests, is required, very important here. And the doctor might choose to add on medication or insulin support for the mealtime in order to rescue her from high glucose and after effects, because her threshold for low as well as high seems to be very, very fragile. She tips the balance very easily. And lastly, we talk about an adolescent with type 1 diabetes mellitus, and we see here this adolescent is on an insulin pump. Insulin pump, for those who are not aware of what insulin pump is, it is given in type 1 diabetes mellitus, where small quantities, small amounts of insulin will be delivered under the skin continuously. So it will be adjusted for their meal period and in between meal period. It is an advanced technology. And this person also takes thyroid tablet, and the HbA1c is at 8%, which again has to be as close to, like, the ideal one should be 48 in young person. And although they check their glucose up to 5 to 6 times a day, they also suffer with low glucose episodes quite frequently, but nothing severe. They had ketoacidosis in the past, and the last episode was about 4 years ago, and they want to fast with her parents during Ramadan for the first time. So the changes that has to happen for this young person who wants to fast is encouragement, motivational counseling. They should be changing their glucose monitoring to one of the technology latest ones like flash or continuous glucose monitoring. Will give them more idea of what glucose levels are doing, and they will feel more confident and in control. They should go on the diabetes focused education for type 1 diabetes, where they will learn how to count the amount of carbohydrate in their meal and then adjust the dose of insulin accordingly. So with this, and they will also need the education around what to do if they develop ketones because of high glucose, and what to do if they develop hypoglycemia in the context of fasting, and when to break fast. So with this, and they will need frequent monitoring or support, at least So prior to the fasting period, one or twice during the fasting period, it could be virtual telephone consultation with their specialist nurses or doctors in the hospital. Usually type 1 diabetes adolescents are under the care of the hospital doctors, so they will have closer support. And then immediately after the fasting period, they need a review to reset to their baseline. So again, high risk category, but with the appropriate support, they can safely fast. And that's the end of my talk. Thank you so much for listening and for your time. And I open it out to the viewers for questions. And I'm going to stop the sharing there.
Well, thank you. I think I can probably speak for everyone when I say, like, it's clear you know so much, not just about diabetes, but also about fasting, and you know, really appreciate that you included a lot of different religious fastings as well, not just the one we're going through right now, which is Ramadan. So thank you. There was one that Naseem put down earlier that I thought was a really good question. It was just saying, when someone does break their fast, what's a good food to eat that prevents the blood sugar shooting up too fast?
A really good question. So basically, so breaking the fast, say for example, if they are on medications, then it would be prudent to kind of not eat too much of sugary substances or sweetened drinks at the breaking of fast. For example, two dates. The dates are usually, as far as I understand, dates are usually used to break the fast in the context of Ramadan. So 2 dates give about, let's say, about 10 grams of carbohydrates. About 4 dates will give about 20 grams of carbohydrate. So that should be enough to shoot up the blood sugar to the safe level, non-hypoglycemic level. And then if they follow the 45-50% carbohydrate, starchy carbohydrate, or whole grain food, followed by 20 to 30% protein, and then less than 35% of fat. If they follow that example, the meal plate example, then they can usually keep the blood glucose within the required range in 2 hours after the fasting. If the person is on mealtime insulin, it would be useful for them to adjust the dose of the meal insulin. They might need a little extra, 1 or 2 units extra doses if they are going to have extra portion for the breaking fast. Usually when breaking fast, we all tend to eat extra portion. It's unavoidable and becomes inevitable. So if they are on mealtime insulin, they can make use of 1 or 2 units extra insulin there. With regards to tablets, there won't be much flexibility or dose adjustments that we can make with tablets. However, if they use the sulfonylureas, for example, if they take the glycoside once a day in the morning, they may choose to take it in the evening when they are breaking the fast, when they are having the meal for the period of fasting. So as I said, these has to be individualized. And that's why if they talk to their doctors, they'll get the right advice.
Cool. Thank you. Thank you very much. Afia, I know you just put down your question. I don't know if you wanted to ask it verbally. You do not have to, but I want to give you that opportunity. So you are welcome to unmute.
Hiya. Yeah, so my first question, I think somebody else in the chat already spoke about it, but that is how do you help with food cravings, because I crave sugar all the time. And the second part is if you don't like to use or do the finger pricking, are the sensor and the glucose sensor machines, or the patches that you put on your arm and the app, are they any good? Would you recommend those?
So Afia, thank you for the question, and that's a very good point that you have brought up here. So if we have to talk in the context of hunger pangs, it is something that happens when people take high carbohydrate food. So I am struggling to understand if there is any health condition in your case. I don't want you to declare it here. But the best way to reduce the hunger pangs would be to talk to the specialist dietitian if you have any. And there will be kind of a switch in the proportion of the food that you eat. Usually hunger pangs settle when there is a high protein and limited carbohydrate meal, and the dietitian would be a best person to start with. That's there. That's that's an answer for part of your question. The other question you asked about is the flash glucose monitoring, or the sensor that goes in the arm. It's called as Freestyle Libre. As I said, the NHS England has and the rest of the national diabetologists have recognized the need and the usefulness of giving it to people with diabetes mellitus. So for people with type 1 diabetes mellitus, we are going to provide to everyone with type 1 diabetes mellitus, but changes are happening at local guidelines, and then you will receive a letter on that. For type 2 diabetes mellitus, it is given to people on certain set criteria. Your specialist will be able to explain that more. For example, I can say if someone is on kidney failure and they require dialysis, they require 3 or 4 injections through the day, they qualify to go on this sensor. If I was to make decision, then I would say it is a really useful tool for all people with diabetes mellitus. So I won't hold it back from anyone. It is really a useful tool, yes. But having said that, the technology, the finger prick test and the flash glucose monitoring have their own advantages and disadvantages. For example, the flash glucose monitoring tends to give you false readings at extremes of values. For example, if very high glucose and very low glucose, it gives you falsely lower value and a falsely very high value. It really matters. It's only a very marginal difference before you choose to treat for hypoglycemia or choose to take extra insulin for high glucose. Therefore, always the traditional method of monitoring the blood glucose comes handy in such situations. So finger prick glucose is also a valid and important means to check your blood glucose and keep on top of that. I know it is a hard call. Nobody likes to inflict pain on ourselves, but there are, as I said, pros and cons in every technology. Thank you.
Thanks for asking both of those, and great questions. Thanks, Afia. Abdi, I can see that you've got your hand up, so please go ahead.
Yes. Hi, Jaya.
Hello.
Yeah, I'm diabetic type 2, and every 3 months I check my blood sugar, and it's very high. It's so high. So I wanted to know, how can I reduce to lower?
So Abdi, so thank you for asking that question. So this is a general forum, so I would struggle to advise tailored or individual advice tailored to your particular scenario. So in general terms, what you can try and do is you can do self-directed learning for type 2 diabetes. So the diabetesbooking.co.uk has got a self-directed learning portal, and you have a lot of information in there. Secondly, talk to your GP. If after doing the type 2 diabetes education, you still feel that you needed specialist input in that, then talk to your doctor, refer to specialist dietitian. Depending on the duration of the diabetes, if it is under 6 years, then you may talk to go on the very low calorie diet where people have enjoyed diabetes remission. It has put them into remission and reduced the, they've come off medications and so forth. It is also available in the Croydon area. And thirdly, so again, the first principles, nutrition and lifestyle. Increasing the physical activity as much as possibly you can. And then lastly, talking to the GP to see if you need modifications to your medications. Would you benefit by going on any of the newer agents that also promotes weight loss? So these are the things I would advise that you consider, Abdi. Thank you.
You, Jaya. Thank you very much.
Hi, I was wondering, if you suffer with mental health, right? And when you're on a low, I actually do a lot of emotional eating and binge eating. So I was wondering how to deal with that. If possible, you can advise us.
Great question. And who did that come from? Naseem, is it?
Yes, it is.
Okay, great question, Naseem. So it is recognized that a lot of comfort eating contributes to increased weight gain, and therefore aggravates the type 2 diabetes scenario. So there are several ways that this can be tackled. There is a lot of emphasis being put on mental well-being, especially in the context of diabetes mellitus. So one is the talking therapies. If that doesn't help, then talking to the GP with regard to referral to specialist psychology, diabetes specific psychologists. They will undertake cognitive behavioral therapy, and they will assess your individual scenario and then advise on to how a behavior modification can happen. So these are the two things that you can look at, and behavior modification is a major thing that has to happen. And also thirdly, if the depression is having such a detrimental effect on the daily activities of living, getting treatment by way of tablets for the initial period until the clinical depression is settled a bit will also be an option. Hope that answers your question, Naseem. Thank you.
Thank you so much. Secondly, I was diagnosed with diabetes 3 months ago, and within 3 months, my eyesight has deteriorated a lot. The meaning of like seeing now, I can't literally see as well as I used to be able to see, even though I wear glasses anyway. Why is that, even though I'm not on medication?
Naseem, my advice would be to contact your GP to get your eyes checked. The diabetes retinal screening, it is really important, and it appears to me you needed medications and the right support and education around the management of diabetes. Although it is only 3 months, you might be suffering with high glucose levels. High glucose levels will cause the eye lens to swell up, and you can have fuzzy vision from that. That is a benign thing. However, the serious thing would be to look at the back of the eye. So therefore, my recommendation to you would be talk to your GP on an urgent basis.
Okay, thank you so much.
Also, I can see there's 3 hands, so I do just want to flag up that we'll be finishing soon. So we'll take these 3 hands, but I won't be taking any more after that. So Nazreen, then Mamli, and then Galaxy.
Hi. I am controlling my sugar levels, which has gone up, controlling by diet and exercise. And I was just wondering if I have in the daytime, if I feel like having a snack, and this is not, I'm not talking about Ramadan fasting time. So if I feel like having a snack and I have something like something with bread or and a toast or something sweet like a piece of cake and a cup of coffee, and then I realize that my blood sugar level might have gone up. Is there anything I can take which has got, I don't know, maybe something I can eat, like a vegetable or something that can help to bring my sugar level down immediately after I eat that? Or could I maybe exercise or something? I mean, I don't want to go down the medication line. I was just thinking where food is concerned or lifestyle ways I could help to reduce it. And the same with if I've eaten a big meal and then I feel like having some chocolate or something after that, and I'm craving it and I have it, and then I'm feeling guilty about it and want to reduce the blood sugar level. Is there anything I can have?
Thank you, Nasreen, for that question. Yours is a specific dietetic question. I would recommend that you go on the Diabetes UK website, which has got Guide to Diabetes, Healthy Eating, and what you can eat around specifically tailored eating. They have got several different recipes there, including Mediterranean diets, low carbohydrate options, healthy snack options. And also I would say that talk to your GP about registering with the local type 2 diabetes education. It is largely run by the dietitian, and the diet is the major portion of the education, especially the carbohydrate awareness education would be really good for you. That would be my recommendation. And one tip would be going for protein-based options would be best in terms of snacks. Thank you.
Thank you. And the next was Mamli.
You've talked a lot about protein, carbohydrates, but I also feel fiber can play a lot of role here because fiber can inhibit the fat, and we talk about fatty acids, reducing them, and then the sugar converts to fat or fat to sugar. So what role will fiber play when there is a breaking time from the fasting, something fibrous that you can have quickly, maybe carrots, maybe anything, cucumber, whatever you can have with a lot of fiber to supplement eating anything sugary or anything with carbohydrate. Will fiber have some use here?
That's a great point that you made, Mamli, there. Yes, when we talk about the whole grain carbohydrates, they are fiber rich as well. Of course, vegetables will have their amount of fibers, and you quoted some vegetables and include spinach in that as well. Yes, of course, they will help in increasing the satiety as well, along with the protein. Yeah, I agree with that.
As far as tiredness goes, low magnesium, will that also contribute to the tiredness?
So it's a very specific question that you're asking. It's very difficult to answer where the low magnesium would contribute, because many minerals and these kind of magnesium, potassium, calcium, they will have overlapping symptoms, but it's very hard to pinpoint what it is that could be contributing to tiredness. So in general, it could be related to high glucose itself, and the body kind of becoming lethargic because it's not able to process and not having enough energy in the context of diabetes mellitus. Yeah, that's one reason. There could be several reasons why somebody could be fatigued.
Yeah, thank you. And then last but not least, Galaxy A40. I will have to make that the last one. Okay. Because I actually am doing another workshop after this.
Hello, my name is Yoga from Empowering Tamil Family. Is it possible to arrange another diabetes information for our community?
So thank you, Yoga. So I would say, Lizzie, can you take that forward? I'm happy. Yeah. Thank you so much.
Thank you, Lizzie. Thank you. Good opportunity. It's very good explanation. Yeah, we need a translation and that and this. That's the reason I didn't invite our community. We want to do separately. Yeah, thanks a lot.
You're welcome.
Yeah,
that's absolutely fine, Yoga. I will organize a Tamil translator for that as well.
Yeah, okay. Thank you, Lizzie. Thanks. Bye.
Brilliant. So before we go, I will just let you know, because they are very relevant to you, that we have a couple of other events coming up. So let me just bring that up onto my screen so that you can see. So we have a coffee morning, which, whereas with Dr. Jaya, we've had like such privilege that it's been so specific. I can't believe your level of knowledge is ridiculous. We're having a more casual, just chat and coffee morning with Sarah Harris on Wednesday, the 4th of May, and that's face to face. So that's probably a little bit more like to get ideas from colleagues as well. And then if you do have any concerns more around your heart, so not diabetes related, then at Matthew's Yard, which is a local cafe in Croydon, we're having an event there with Nurse Michaela, and that's on Sunday, the 22nd of May. So we're doing it on a Sunday to try and capture, I know I get a lot of comments saying, oh, don't do it on a weekday because I work. So hopefully we'll capture some other people there. And then this will be really, really useful for those of you who are asking about the eyes. So we're actually having a diabetes session actually at Croydon Vision with them about the effects of diabetes on our eyes. And it's actually at Croydon Vision itself, which is on Wellesley Road. And that's on Thursday, the 26th of May. And it's completely free to attend, but there's only 25 places. So do go onto our Eventbrite if you want to book. And the session itself is free, but if you want, you are allowed to pay £5 and get lunch at the same time if you wanted to. So I will stop our share there and basically just say a massive, massive thank you to Dr. Jaya. I mean, I can't believe how you have all that information in your head. It's amazing. So I think, yeah, big, big, big thank you. And thanks for answering our questions as well. Cool. So I will upload this to YouTube, so please share with people that couldn't attend.
Can we do the poll, Lizzie, quickly?
If it will work. Absolutely. Here we go. So it launched. So there should be a poll up now. I know that not everyone's here, but in front of you, there should be a question. It says, I understand how fasting affects people with diabetes. And you literally just click on the answer that you feel helps. Obviously, if you joined in halfway, it might be a bit tricky. Brilliant. So if I just end that there, and then I can share that with you. So brilliant. So we've got strongly agree, which is very nice. I know people don't like to go one extreme to the other. So 60% strongly agree, 20% agree, and then 20% strongly disagree. So well done, Dr. Jaya. You've obviously helped some people understand, which is fantastic. So thank you again.
Thank you all. Have a good evening. Bye-bye.
Bye-bye.